So good evening,
Yeah.
everyone, and thank you, Dr. Rajneesh, sir, for inviting us to a great platform. So I'll be discussing my case today, which is an case of Averted CABG. So the story belongs to a 58-year-old male who was smoker, had an exertion angina function class 2 for the past 9 months. His vitals were within normal limit, and the system examination was also normal. Lab parameters showed no significant abnormality. ECG though showed a Q plus T inversion in V1 to V6, and echo showed a hypokinetic LED territory with a ejection fraction of 40%, suggestive of old interval MI. So he went under an diagnostic angiogram outside at some other hospital, which showed an LMCA of 4.5 millimeter with no lesion. LED having a osteoproximal CTO filling retrogradely via retrocollaterals from right coronary artery. Circumflex 2.75 mm having a ostial discrete lesion of 80%, and distal circumflex also have another lesion of 70%, which was borderline, and RCA was having a fairly normal with no significant lesion. He was advised for a bypass surgery, but he denied, and because he was reluctant to go under a CABG. So we, after reviewing this patient, we decided to go for a angioplasty. So this was the first check shot. We say that there is a significant lesion at the LMC bifurcation with an complete near total occlusion of the left anterior descending artery, and there is a discrete eccentric 80% lesion at the ostium of the circumflex. So we started doing first the PTC of LED. We decided to use a CrossFit 200 XT wire. After multiple attempts, we were able to pass into a first diagonal, and we pre-dilated with the proximal portion of LED with the 2.512 balloon. After that, we were able to pass a wire into the distal LED, and we further dilated with the 2.512 balloon multiple times to open up the LED. So LED opened up, and it showed there is a diffuse disease from proximal to the distal portion. However, there can be some portion of spasm also. So we decided to go ahead with the further with the case. We wired the circumflex of the BMW and pre-dilated the osteoproximal LED with another with the same 2.512 balloon again. So we, after dilatation of multiple times and giving nitroglycerin, we've seen that the most significant portion involved was the LMCA bifurcation and involving the ostium of the both LED and circumflex. And we decided to go for a DKDC technique in this particular case, because since both the ostium were involved, and we decided to stent both the vessels because of their significant size and myocardial supply. We pre-dilated circumflex to LMCA with a 2.75 balloon, keeping another 2.512 balloon in LED as a precautionary measure. And we decided to stent the LMCA to L6 with a 2.75 drug-eluting stent, keeping the 2.758 balloon in LED. The stent was deployed from LMCA to circumflex, and after first check shot, crush with balloon of 2.75 in LED. So we wired the, and by this time we noticed there is a significant, because of our poor quality of cath lab, it got overheated and we were not able to record fluoro and synase. Somehow we were unable to remove the balloons in an easy manner from the wires, and during the attempted removal of the balloons from the vessels, there is a complete loss of guide wires from both the vessels, leading to a complete loss of control. So after that, we have taken the check shot when the cath lab resumed its function after heat passage. We saw there is a flow in both the vessels. However, there is some thrombus formation, particularly in LED. And even though there is some dropping of the blood pressure, we given some inotropic support of NORAD. And after that, we immediately rewired both the vessels, LED with a fielder XT and circumflex with a BMW wire. We pre-dilated LMCA to LED again with a 2.7512 balloon to ensure that there is some flow is maintained into the LED. And after check shot, we can see there is no flow in the distal LED, probably because of the thrombus embolization into the distal portion, leading to no flow. So at this time, we decided to stent immediately the osteoproximal portion of the LED, so that we do not lose any flow in the LED furthermore, leading to a cardiac arrest. So our LMCA to LED was stented with a 3 to 32 drug-eluting stent. And this was the check shot taken. So after deploying the stent, we can see the flow resumed even in the distal portion of the LED. It was TIMI 2 flow. And after rewiring the circumflex through the LED struts, we given a second kissing balloon inflation with a 312 and 2.758 balloon. And finally, we are given a pot of 48 NC balloon LMCA. We were not able to record the CNA because of our cath lab issues. And this is the check shot we have achieved, that there was a nice TIMI3 flow in both the vessels with no significant residual lesion. And we were able to save the patient after intervention and handling a complication. So this was the pre-PTCI and post-PCI pictures. So we learned from this case that though the bypass is the recommended treatment of choice in these kind of cases, particularly CTOs, LMC, and bifurcation diseases, but where the patient is reluctant to go under a bypass, the patient can undergo a PTCA if done in a proper meticulous manner. With the availability of newer techniques and gadgets, it's a good reasonable option. And the complication they do occur, especially in peripheral center where we are short of hardware, and even the procedural cost we have to keep it at a minimal low so that the patient is able to afford the procedure. Backup in form of IBP, CTBS backup and ventricular assist device is useful. And if we don't have a support of intravascular imaging at our center, however, if it was available, we should have used that. Thank you so much.
Thanks, Ashish. So this was a wonderful case actually, and you had the fireworks in between also while you lost both the wires. And by the time I think you had crushed one stent, so it was worst time to lose the wires after having the first crash.
Yes, sir, you are right, absolutely, and that's why patient developed hypotension, and we have to put him on immediately inotropic support. We were lucky enough to rewire both the vessels without much of a difficulty. Otherwise,
that's what I was coming to and trying to ask you. While you rewired, you faced any difficulty? Because one thing which I think we can discuss here for the sake of all the guys sitting here. You mentioned that you kept 2.75 balloon in the LED while you placed one stent from left main to sub, and then trying to crush with 2.75. So normally for DKDC, it is mentioned, you should at least have the balloon of the other vessel caliber, because if you are just crushing the stent suboptimally, you may face a difficult advancement of other stent into the other main vessel, where you're putting another stent. So I believe it should be 3 in this case, or could be 3.5 also, because you were crushing in the left main. So that is one thing. It has to be a very vigorous crush, because otherwise it may give a problem. So you are lucky that you got away, and even after losing wires. So I would compliment you on that. It requires bold maneuvers to keep on doing such things. I mentioned to start with that at peripheral center things are not easy. They look easy, but you are short of hardware. These things like the lab going down or lab switching off, these things may happen. So I think this is a real proud feeling to be working in periphery and pulling off such a difficult cases. So besides this,
yes, sir, you are right. Yeah. We should have used a larger balloon, but the reason of using 2.75 for crushing in LED was that we had to use an Oxford balloon in that case, because we want to keep the cost at the minimum. We could have used open up 3 balloons and straight away, and probably the procedure has gone up, and which would be also a difficult thing for us to manage at that time.
I know. So DKDC, the main issue is this: it's cumbersome technique, and it requires almost 2 to 3 new balloons. It may require. So otherwise, very well done case, Ashish. It's a remarkable result in the end, and again a bold case. So all the points to you for that. Keep it up.
Thank you, sir. Thank you so much. Thank you, sir.
Yeah, right. And be here, because after the 4 presentations, we'll decide about the best case presenter award also. So next, who's next? Dr. Sahil. Yeah. So Dr. Sahil is here. I introduced him prior to this presentation. So Dr. Sahil, over to you for your presentation, and welcome to our